Yes, ma'am, we are live now.
Yes. Good evening to all. And I welcome Dr. Sindhya Madam, Dr. Bhaskar Pal sir, and Dr. Revati Madam, and all the faculties for our Marathon CME. This Marathon CME, why it is called Marathon CME is every month, second Friday, we used to conduct this Marathon CME in 3 sessions. First session will be for Yuva. The Yuvas, 2 Yuvas will give a talk, and they will have the same judge, Dr. Nidhi Sharma and Dr. Vijay Lakshmi, being the judge for more than 2 years. At the end of that year, that is in the TNFOG annual conference, Best Yuva will be given a award, Best Speaker Award. So that's the reason it is called as Marathon CME. And the second session being with the seniors. And third session, we have the panel. For all Marathon CME, we have a theme. This October 11th is International Girls Child Day. So today we have taken the theme as Adolescent. So all about adolescent. This is our today's theme. Now I welcome Dr. Radhika Gauri, who is the MOC for this Marathon CME program. Dr. Radhika, you can take over.
Thank you, ma'am. Thank you very much for the opportunity. Good evening to all the senior teachers and all the professors and the speakers. Welcome everybody. And we will start the interesting session about adolescent gynecology with Tamil Thai Valthu. Auspicious lamp lighting. Next is the welcome address by our Professor Dr. Revati Janakiram ma'am. She was a former director, IOG.
Just say President TNFOG. See, that's enough.
And President TNFOG.
Thank
2023.
you. Thank you. Good evening, all. It is indeed a great pleasure to welcome all of you to this Marathon CME, specifically for adolescent gynec problems. And it's my privilege to welcome our chief guest, Madam Sindhya Madam, guest of honor, Dr. Bhaskar Pal, and ever bright permanent judges, Dr. Nidhi Sharma and Vijay Lakshmi Kandasamy, and also today's speakers, Dr. Anit, Dr. Danya, and Supriya Jaiswal, and also chairpersons and the panelists also. And I welcome all the delegates too, who are going to definitely gain a lot through this program. I welcome you all. And Dr.
Madam Chief Guest of Honor,
Madam's CV, please. And all of us know about Cynthia Madam, such a nice, pleasant lady. And she's a good singer also. You may not be knowing.
Yeah.
ரொம்ப நல்லா பாடுவாங்க. Former director IOG, superintendent Women and Children Hospital, and she has been awarded Lifetime Achievement Award from Tamil Nadu Major Medical University and also from DIPSI at Lucknow. She has received also Times of India and Economics Times Award in New Delhi in 2018. Over to you, madam, to say a few words to bless this.
Thank you. So, good evening to all. And I feel honored to be the chief guest of the day. My wishes and thanks to the officers of TNFOG, Dr. Revathi, Dr. Sampath, and Dr. Vijayalakshmi. I received a few messages last night to remind me of today's program. Dr. Radhika Gauri, Dr. Shanti all called me and all to tell me that they were with me as postgraduates. Fond memories I recalled. Also, so many stalwarts across boundaries from many states and from many districts of Tamil Nadu. We are very grateful to Dr. Bhaskar Paul for being with us this evening. And now coming to the theme of the day, all about adolescence. Some famous lines come to my mind. What we sow, so shall we reap. Another thing, we care for the next generation, who is the wealth of tomorrow. And again, as we groom our adolescence, we shape the future. Actually, adolescence is coming from the Latin word adolescere, which means to grow up. It's a transitional period of physical and mental development that occurs between childhood and adulthood. WHO says a period of life between 10 to 19 years. And we have 3 stages: early adolescence, middle adolescence, and late adolescence. As we recall our adolescence, we recall with fond memories how we were admired, how we blushed. A wonderful period in a girl's life. But again, not all are lucky or safe. Their adolescence is fraught with problems: physical, poverty, sexual, psychological, emotional, moral, and social problems. And education plays a major part in this stage of life. So in the early years, they were looked after by the pediatrician and later by the gynecologist. And as health care workers and experts, how far have we taken care of our adolescents? Their physical growth, their menstrual problems, educate them about their personal hygiene, nutrition, moral and social responsibilities. And again, they are our future citizens. And again, what is our role of looking after the LGBTQ group also? So as we aim to make our India incredible and free, empowering our women, are we focusing on making our country free from diabetes by 2047? So that we can prevent the NCDs, which is wiping away our youngsters. We must target our young girls and boys before it is too late. Equip them with the strength and knowledge to prevent NCD in their lives. So as we celebrate the International Girls' Day on October 11th, we wish all the girls, known girls, unknown girls, a happy and healthy International Girls' Day making them healthy and safe citizens of India, so that we can quote Rabindranath Tagore by saying, where the mind is without fear and the head is held high, into that haven of freedom, let my country awake. So it is our duty to go along with our adolescent girls and boys so that we create a healthy, safe India in the future. So thank you very much for this opportunity. Thanks a lot. Okay.
Thank you, madam, for your nice words and also making all of us recall our own adolescent days. Thank you very much. And it's my pleasure to welcome and introduce our guest of honor, Dr. Bhaskar Pal. And he is the past past vice president of Oxy in 2017. And also he was the examiner for MSUG Part 3. And all of us know his organizing capacity in this recent ASUG at Calcutta in 2023. And
Madam, that would be enough.
In Apollo Hospital in Calcutta. And he's a very good academician, and every one of us would love to listen to him, especially all his lectures. So over to you, sir.
That would be. Thank you. It is thank you, madam, for the kind introduction. It is indeed an honor to be the guest of honor today at the TNFOG Marathon CME, and I'm grateful to Dr. Revati Jankina, madam, and my dear friend, Dr. Sampath Kumari, for inviting me for this. My respect to Dr. Cynthia Alexander and all the seniors, and my regards to all my friends and colleagues. Now, madam has already said that the adolescents are the future of tomorrow, so we need to invest in them. And we talk of women empowerment, and there are numerous social studies which show that the best way to empower women is by educating them. Nothing else, not by putting money in their hands, that they'll find it themselves. So women get empowered when we educate them. So Dr. Sampath Kumari has always been a champion of adolescent health. And I'm sure that I like this structure of the program. You start with Yuva, and then I have my dear sister, Dr. Supriya Jaiswal, giving a talk, and then we have a panel discussion. I wish this meeting a very, very fruitful meeting, and I'm sure that everybody will take home very useful points. Thank you.
Thank you. Thank you very much, sir, for sparing
Thank
time
you,
to
sir.
attend our CME. Over to Dr. Radhika to introduce the judges of the Yuva session.
Okay. Thank you, ma'am. Moving on to the Yuva session, Dr. Nidhi Sharma is our first judge, and Dr. Vijayalakshmi, ma'am. I welcome Dr. Nidhi Sharma, who is a professor of Obs and Gynae at Savita University, and she's done her UG and PG from Banaras Hindu University, Varanasi, India, and she's a member of FIGO and fellow of ICOG, and she's also fellow of Assisted Reproductive Techniques. She's done a PhD degree in Obs and Gynae from Savita University. She's academic supervisor of fellowship in reproductive medicine, MSc in clinical embryology at Savita Medical College. She's also received numerous awards and
thank you, ma'am.
prizes.
Thank you so much, ma'am. You can go ahead, ma'am.
Thank you.
Nidhi, you have to include that peer reviewer of Johi. You are not
yes,
including in your CV. She got the
yes.
best peer reviewer award last year.
Yes.
Congratulations.
Thank you so much, ma'am. Thank you.
Okay.
And I welcome Dr. Vijayalakshmi, ma'am, who is a professor of Chettinad Hospital and Research Institute, Kelambakam, Chennai. And she has received numerous special prizes, and she has achieved and awards for exemplary performance in IMA activities in 2021. And she is the president of Velachery branch of IMA and chairperson Women Doctors Wing, IMA Velachery. Has special interests on high-risk obstetrics, adolescent gynecology, and gynae endoscopy. And she has held important posts in OXY and other major bodies. Over to you,
Thank you.
madam.
Thank you. Thank you,
Vijayalakshmi is
madam.
also HOD of Chettinad Hospital. She is mentioned only professor.
Professor.
She is HOD of Chettinad Medical Hospital.
Thank
She
you.
is
Thank you,
student
madam.
is with us.
Actually, being a judge is more difficult than just giving a lecture. So I really appreciate the courage with which they continue to be the judges continuously for the past 2 years.
Thank you, madam.
Thank you so much, ma'am.
It is all
Thank you
Sampath
very much.
madam's constant encouragement for both of us,
Thank-
myself
thank
and
you.
Nidhi, madam.
Welcome.
Thank you,
Really.
ma'am. Thank you.
Our
Okay.
student is our SR ma'am in ESIC.
Oh.
Vijayashri ma'am student.
Oh,
Okay.
very nice to
Welcome.
note.
Yes, both of you.
Can introduce the Yuva speakers.
Yes, ma'am. It's my pleasure to welcome Dr. Anit Kumar, MS, MRCOG, DRM. Dr. Anit graduated MBBS from PSG IMSR. He did his post-graduation from Madras Medical College. He did his diploma in reproductive medicine from Kiel, Germany. He is an andrology certified clinician from the Cleveland Clinic, US. And he also did his MRCOG and he's a fellow of reproductive medicine. Presently he is working as a consultant at Sri Kumran Specialty Fertility Center. His interests are laparoscopic pelvic surgeries and reproductive endocrinology. He has won paper presentations and quiz at various national and international conferences. We welcome you, Dr. Anit. You can start your presentation.
Thank you, ma'am, for this.
Anit, 1 minute, 12 minutes presentation and 3 minutes question.
Yes, ma'am. Thank you, ma'am. I thank you, Sampath Kumari ma'am and Revati Janakra ma'am, all the office bearers of TNFOG for giving me this wonderful opportunity to part of this Yuva presentation series. So my talk given to me was adolescent endometriosis. And adolescent endometriosis is been given a lot of recent focus online, and I thank the organizers for giving me such a topic of interest that is actually personally very interesting to me also. So endometriosis starts at the very beginning of a woman's life. This is a study that was published in 2011, and you could see that around 18% of endometriosis prevalence is in the age group of 10 to 19 years. So less than 20 years, almost 20% of population of prevalence of adolescent endometriosis is there. And if you look at the overall chart, 64% of women who suffer from endometriosis are less than 30 years, and they are in the prime reproductive age, and it becomes really challenging and really mentally agonizing time for all these women who are in those reproductive age. So one thing that was discussed in the 2016 consortium was on the endometriosis consortium, the worldwide consortium that was discussed was adolescent endometriosis. Adolescents in the endometriosis group should be given more importance, and more research should be focused on this particular group of people, and they needed to be what treatment could be done, and what is the best way that we could help as clinicians to them. So adolescents in particular are the underserved group with high morbidity and social impact, and at this age is likely the critical window for disease etiological discovery and intervention. The etiology of disease starts from this adolescence, and early intervention at this age could prevent the lifelong suffering of these women. So when does actually endometriosis start? Does it start even before the child is fertilized? Does it start at birth, or is it starts occurring at the menarche? And now we know that endometriosis can even occur in menopause. And Ashriya, as in the recent guidelines, have given a lot of importance in the menopausal endometriosis also. So going into fertilization, so family history of endometriosis puts the child that is going to be fertilized, going to be formed at risk of endometriosis at the beginning itself. At birth, the genetics play a major role. And after menarche, the various environmental exposures that the woman is being put to, let it be lifestyle, let it be food, let it be the various toxins she gets exposed, all could have, play a major role in the development of endometriosis. So the first symptoms that she's going to experience is pain. So from that, and the important thing that we need to keep in mind is that a teenage girl is not going to visit a gynecologist right away for the endometrium. She is going to visit the local primary care physician, the local GPs, or the PHCs with the pain. And that is where the adolescent endometriosis is getting lost. So we should take lots of pains to make sure that the knowledge of this endometriosis and this pain is being brought to the lowest primary care physician at the PHC level. Make sure that these women do not get missed, and it's get treated. And then further on, they either go in for medical or surgical and they have pregnancy, infertility, and lifelong they are into some care of treatment once endometriosis is. That is how debilitating this disease is, and it could be a huge financial, social, and personal impact for the woman that needs that with endometriosis. So the severity of endometriosis actually starts even before the woman attains menarche. So this was a wonderful, this chart that I came across in this 2020 NEGM journal that got published. So this paper discuss about how the endometriosis actually develops, and as I said, even before fertilization, the parental risk, genetic risk puts the baby at risk, and a woman at low birth weight, small for gestational age, and Mullerian anomalies, which are one of the major reasons for endometriosis, we know, are decided at birth and during the child age, early age of menarche, or low body mass, a low BMI can put the girl at increased risk of endometriosis. And then throughout her adolescent periods, any short menstrual cycle, increased menstrual flow, low body mass index, and importantly, infertility. There is always an ongoing debate. Does infertility cause endometriosis, or an endometriosis cause infertility? So increased nulliparity also causes then a woman to go into risk. And the most important thing is, lot of women, majority of the women, they even struggle for a diagnosis. They do not know why they have this symptom. They do not know why they are having pain. And throughout those things, they get diagnosed. So then we know about, now having talked so much about adolescent endometriosis, moving on to adult endometriosis. So does the arbitrary age of 18 years is the correct age that we can say that the adolescent becomes an adult? And does adolescent endometriosis actually change? Or even if it is changed, is the disease progressive? These are the questions that needs to be answered. These are the questions that needs to be pondered, and these are the topic of research that needs to be thought about. So what causes endometriosis? The short answer is we do not know. There are a lot of theories like coelomic metaplasia, where there is an ongoing stem cell changes that occurs which causes endometriosis. There are small embryonic remnants that becomes endometriotic tissue as the child goes. Then mulleriosis, where during development of the fetus, that endometriotic tissues get implanted, and retrograde menstruation, where during the backflow of menstrual blood causes endometriotic. This in record. And even though these theories there are important contributors that are said to make the endometriosis severe in the recent times. There could be altered cellular immunity, immune system responds to different person to different ages. So this could be a very important theory that is coming up. Hematogenous and lymphatic spread is what that causes, the distant endometriosis in the skull, endometriosis in the ear, endometriosis in the throat, nose, iatrogenic metastasis that we have seen in cesarean sections and vaginal deliveries, and then a strong genetics and a family history too. And adding on to these contributors, there are also insults. Now we are talking about environmental factors like toxins in our food, packaged food, microplastics. All these could also be a little bit adding an insult to the fire, which can cause to the endometriosis in the woman. So endometriosis really starts at the check. So this is a big reality check for all us clinicians who think that the girl comes at 18 years old and then she has pain. But we need to keep in mind that endometriosis really starts at the very beginning. There is also a new theory that is being put forward that neonatal bleeding can also cause endometriosis. And we know that around 3% of women, girls at birth have neonatal bleeding. So that could also be a major important cause for endometriosis. And why we say that adolescent is a very important time for us to diagnose, because the immune system is said to not be fully developed at the adolescent stage, and endometriosis, we can intervene at this stage, and endometriosis is the most progressive at this stage. And we know that as the age increases, the severity is increased. And at this young age, the pain gets centralized. So the pain symptoms, all symptoms of endometriosis increases during the adolescent age. The primary challenges that we face during diagnosis of endometriosis is the pain, primary dysmenorrhea. and normalization of pain. So one of the things that GP goes, or the mother or the relative of the child, they say pain normal. It is normal that you have pain during menses. So just leave it. Take painkillers, go to school. And intimidation to the providers, they go to a doctor. So we as doctors, we need to be very sensitive, very careful in handling the small girls in about this pain. So we should, the doctors needs to be very kind and approaching, and you should not, say this is a pain that goes away. You need to hear the symptoms. And because of all this, there is always a diagnostic and a treatment delay for these women, and when and how to intervene. So early diagnostic surgical intervention has also put the women at the risk, and we need to develop, as in India, we need to develop proper proactive care plans for these women to get diagnosed very early on. So getting to the root of the endometriosis is development of the phenome, and endometriosis will lead to an improved understanding of the disease. We need to also identify certain subgroups of types of endometriosis, which can help in non-invasive diagnosis, targeted treatment, prevention of endometriosis, and comorbidities. And as the whole, we need to plan a stratified medicine so that endometriosis gets diagnosed and prevented and gets treated at the root cause of all the problems. So there's a lot of guidelines. We have the New Zealand guideline that came in 2020, NICE guideline. A lot of consensus is there. And the most important is the HRA guideline that came in 2022. What does the summary of this guideline say is, you need to take careful history. Taking a positive family history is a very important thing. Look for absenteeism in school. Look for any pain symptom. Even one pain symptom actually points towards the diagnosis of endometriosis. Look at the cultural and background, and you can do transvaginal ultrasound, but I don't know how much it is in our country. It is more, but you could do an MRI, and diagnostic laparoscopy is this thing. So some summary of the management, you need to look at the, you can do the ultrasound. Transvaginal ultrasound is what is recommended by the HRA 2022. Might not be this thing in our country. You can do an MRI, don't do biomarkers. NSAIDs is the first line, add on contraceptives if needed.
One more minute, doctor.
Laparoscopy, yes, ma'am, finishing. Laparoscopy can be done, but even if it is a negative laparoscopy, do not forget that there could be a possibility of endometriosis. Yes, you can put her on OC pills. LNG IUS is another treatment, but in adolescents, it is still a query in our country. But HRA does recommended it. NSAIDs is the first line. Laparoscopy can be done. And then there is, this is something new for me in this guideline. They say that GnRH agonist can be used in adolescents, and they can be used up to a period of 1 year. And you should add on therapy to make sure they don't go into menopausal symptoms. And all the endometriosis symptoms can recur. You need to have a proper conversation with those girls, and you need to monitor post-op if you're offering surgery for her. Concluding, early recognition and symptoms of suspicion of endometriosis should be there. You should empower our primary healthcare practitioners to make a diagnosis and suspect and commence management. And you should train, all the PHC level should be trained. It should be a multidisciplinary workforce in both primary, secondary, and tertiary care, and improved equity of access and health outcomes patients should be there. Thank you.
Thank you, Dr. Anith. Can I ask you one question? Yeah, can you highlight the role of HOXA genes? HOXA genes in endometriosis and HOXA genes in Mullerian anomalies.
Yes, ma'am. So
Homeobox
homeobox gene oxygens is very important for the uterine structure development. If the genetic defect is there, it could cause to Mullerian agenesis, all the Mullerian anomalies, and they have found to be some role, but not yet confirmatory whether endometriosis, it can have an endometriosis or not.
Okay. And another thing, suppose if you are giving, second question, you are giving GnRH agonist to adolescents, isn't it? So what are the problems, like how you will face, like suppose I do prescribe it?
Yes, madam. So the first problem is convincing the girl and the parents that she can need monthly treatment. This is the last line of treatment. The first line is ocipils, first line is NSAIDs, the second line is ocipils, and third line is agonist. The problems that I face when I put on agonist is convincing the mother, and then menopausal symptoms that hot flushes, you need to put her on estrogen and progesterone as an add-back therapy. So another third problem that we can face is the continuation of the treatment, whether they'll take it for a period of 12 months. So this is a short gap therapy, and it may or may not work. So that could be a problem that we will be facing.
Any role of oral GnRH antagonists like elagolix?
I mean, it has not yet been verified in adolescent, but in adult endometriosis, they have suggested that GnRH antagonists can be used, and it has been recommended in the recent HTA guidelines also.
Thank you.
Thank you, Dr. Annette. Yeah. Yes, it was actually a thought-provoking talk from you, a presentation. What's the earliest age that we have actually documented endometriosis in young girls? You said it could begin even in childhood, isn't it? In infancy also. So what's the earliest documented age at which it has been picked up? Any idea?
No idea, madam. I didn't go through that. But it has been from the first period of menses also, like as soon as she attained menarche, there have been reports of endometriosis aspect is there.
Yeah. It has even been reported in a girl 7 years old, pre-menarcheal girl 7 years old. So as you said, we really don't know what causes, but it is coming even in has been picked up at a 7-year-old girl. Yeah.
Thanks.
Yeah. And what is the role of using, you did say GnRH agonist, I mean antagonist, but what about Dynogest? What is your thought on the use of Dynogest?
Yes, ma'am. Dynogest is a good option in adolescent endometriosis, adolescent age group, definitely.
Yeah.
And it is classified under the group of progesterones in the HTA classifications, and standalone progesterones could also be a treatment options for adolescent endometriosis. And it could be also used for long term, 2 years, 5 years studies are there now to support us.
Yeah. Thank you, Dr. Annette. Thank you.
Any problems of flare response? Any side effect about flare response of GnRH?
Especially, yeah.
It is just I'm not sure, madam.
No, yeah, no, flare response is actually high.
When you're going with the
adolescent age
antag,
group.
probably, yeah.
Yeah.
Yes. Thank you, Dr. Annette.
Thank you.
Yeah.
Thank you, Dr.
There is a question in chat box, Dr. Annette. How long to use Dynogest? Maximum time. There's
Revati madam, only judge can ask questions.
No. Chat box la iruke. Chat box la irukku solla.
Recent studies
அது
are
அவங்க அப்புறம் சொல்லிக்கலாம். ஆனிட்டு இருக்க வேண்டாம். அது வேணா ஜட்ஜ் சொல்லிட்டோம்.
Yes, ma'am.
We have girls, teenage girls who are on Dynogest for the last 1.5 years as well, so continuously, and with great relief of symptoms.
Yes.
That is the longest I have seen. I have personally put it on a college girl, and she's on it for the last 1 year fully. Documented endometrioma, but she's responded well. What we are looking at this age is mainly the pain symptoms, relief from the pain symptoms, isn't it? And it really works. But to note that surgery is the final option for them. Yeah. Can we have the slide of the next speaker? Yeah. Next speaker is going to be Dr. Dhanya Shanmugam, who is a junior resident in the Department of Obs and Gynae at Dindikal Medical College and Hospital. She has graduated from TNE Medical College and has her TGO from Madurai Medical College, and she has a fellowship from Lab Gynec Endoscopy, a member of the IAG and consultant at Rajan Clinic Dindikal and Aishwarya Fertility Center Dindikal. Over to you, Dr. Dhanya, for talking to us about adolescent PCOS.
Good afternoon. I thank all the judges and the senior most consultants for giving me this wonderful opportunity. Okay, I'm just moving on to the topic. So the topic given to me is adolescent PCOS. So it is not a disease, it is a syndrome with varied presentation, and the PCOS constitutes a continuum of spectrum starting from the early pre-pubertal years and continuing even after menopause.
Your slides are not visible.
Share screen, ma. Share your screen.
Yes, ma'am, one second.
Dr. Dhanya. Yeah. Sahiti, share screen is enabled for her.
Yes, ma'am. Please open the PPT, ma'am. Yes, and also make it full screen.
Yeah.
Thank you, ma'am.
So coming to the epidemiology, is the incidence of PCOS in adolescents rising, or has the diagnosis improved? So the answer is yes. There is an increase in incidence of PCOS in adolescents, as well as due to the introduction of many criteria, like in 1990 by NIH and by Rotterdam in 2003 and AES in 2009. The cases have been picked up even more. In 1990, by NIH, it was the criteria were either oligo or anovulation and hypoandrogenism or hypoandrogenemia. And Escher had given Rotterdam in 2003 to include 2 out of the 3 of the following, which included the oligo or anovulation, clinical and or biological signs of hypoandrogenism, and polycystic ovaries. By AES in 2009, the criteria were hyperandrogenism, either hirsutism or hypoandrogenemia, or ovarian dysfunction, which led to oligo or anovulation or polycystic ovaries. And important thing was exclusion of other androgen excess or related disorders. This is the slide showing all the criteria that were proposed. So coming to the familial history, like, is there any familial history of PCOS? There is almost like 40% if her sister is having PCOS, and there is 20% incidence if her mother had already suffered PCOS. So which hormonal or blood tests are to be done to confirm the diagnosis of PCOS, and which tests should be done before starting insulin sensitizers? Is it like fasting, postprandial blood sugar, or insulin, or HbA1c? So the basic profile which we have to look for will be, to rule out thyroid disorders, we have to look for serum TSH, and hyperprolactinemia, we have to look for serum prolactin, and Cushing syndrome, DEXA suppression test, late onset congenital adrenal hypoplasia by fasting 17 OHPs, and ovarian and adrenal tumors, we have to see DHEAs, and WHO 1 and 3 suggest like FSH, LH, and E2, and syndromes of severe insulin resistance like Hayram syndrome should also be ruled out. So 2 hours OGTT using fasting and 2 hours blood sugar levels are needed. The normal level is like of fasting is below 100, and postprandial should be less than 140. And if the fasting is between 100 and 126, and the postprandial is 140 to 199, the patient falls under impaired glucose tolerance. And if the fasting is over 126 and the postprandial is over 200, she falls under non-insulin dependent diabetes mellitus. So insulin levels are not really needed for the diagnosis of PCOS. So this picture shows the peripherally arranged follicles in the PCOS. So the criteria in the polycystic ovarian morphology is presence of 12 or more follicles in each ovaries, which may be around 2 to 9 mm in diameter, and or increased ovarian volume of more than 10 ml. It is a fact that PCOM, that is polycystic ovarian morphology, is present in 20 to 35% of girls with normal menstrual cycles. And in contrast, there are patients with typical PCOS who do not have a PCOM on ultrasound. These are the phenotype identified like type A, B, and C. A comprises of hyperandrogenism, chronic anovulation, and polycystic ovaries. Type B is hyperandrogenism and chronic anovulation. Type C is hyperandrogenism and polycystic ovaries. And type D is chronic anovulation and polycystic ovaries. So hyperandrogenemia is the hallmark. So which are the most commonest symptoms that women with PCOS will present? There are like 3 most common symptoms: menstrual disorders, obesity, hirsutism, and acne. So it is a cooperation and coordination among the specialists of all these. So the menstrual irregularities will be around 70%, which comprises of oligomenorrhea of 50%, amenorrhea in 10%, abnormal heavy bleeding in 10 to 15%, hyperandrogenism in 70%, where acne will be seen in 70%, hirsutism in 70%, alopecia in 10% as seen by gynecologists, and obesity in 50 to 60%, normal menstruation usually seen in 20%. This is the picture showing the symptoms. So what is the pattern of menstrual irregularity? As already said, there will be delayed period, which is the most common one. There'll be only withdrawal bleeding, then absent periods, heavy menstrual bleeding, or menometrorrhagia with anemia. So menstrual problems are present in almost 80% obese PCOS and 30% with lean PCOS. 20% PCOS have normal cycles. It is well accepted that if menstrual irregularities persist for like 2 years after menarche, then the risk of PCOS is extremely high, like say 70% of the cases. So coming to the treatment for the hirsutism, acne, alopecia, the Fehling-Arie scaling is the model quantities, the extent of the hair growth in 9 key anatomic sites. The hair growth is graded using a scale from 0 to 4 for a maximal score of 36. A score of 8 or more indicates the presence of androgen excess. However, nowadays we are not using it practically. So the biochemical tests involve like total testosterone levels and 17 hydroxyprogesterone level to rule out late onset CAH in all that is all which is needed. Free testosterone and percentage of free androgen index have no role in diagnosis. Also, aldosterone does not have any role. Any sudden onset of these symptoms suggests like other differential diagnosis of Cushing syndrome, adrenal or ovarian tumors. So the grading of acne are like this: grade 1, 2, and 3. Acne are classified as non-inflammatory, 2 has inflammatory, and a combination belongs to the 3. So these are treatments of the acne, which includes topical applications and oral antibiotics, isotretinoin of 0.5 to 1 milligram per kg body weight. And for acne, which is not responding either topical or isotretinoin, a patient can be given pills which contain cyproterone acetate for 6 to 9 months. Any pill containing desogestrel, that is Femilon, is also effective in a good 80% cases. Coming to the treatment of hirsutism, all combination OCPs are effective, and OCPs decreases androgen levels by suppressing the LH and stimulating sex hormone binding globulin. It takes almost 6 months when decreased growth of hair is noted. So OCPs with low androgenic progestins like norgestimate, desogestrel may be most effective for acne and hirsutism. Metformin and Percy are not needed to reduce hirsutism. Androgen receptor blockers, full clinical effect may take about 6 months. We can give spironolactone of 25 to 100 milligram BD for almost a period of 6 months. So which is the combined oral contraceptive pill, which can be like pills which can be preferred here? Either it is like levonorgestrel or desogestrel, cyproterone acetate, or drosperinone. So any low dose COCs can be given. The OCs containing progestins such as norgestrel, levonorgestrel, and desogestrel are preferred. If hirsutism is a problem, then cyproterone acetate is preferred. Drosperinone has no advantage in hirsutism. So non-androgenic progesterones are desogestrel 0.15 milligram plus ethinyl estradiol 30 microgram, that is Novelon. Desogestrel of 0.15 milligram and ethinyl estradiol 20 microgram, that is Femilon. And anti-androgens with progestational activity like cyproterone acetate, which is like 2 milligram, that is Dianine, and drospirenone, ethinyl estradiol 30 microgram plus desogestrel plus drospirenone 3 milligram, which is Yasmin. So ideal for hirsutism will be cyproterone acetate. So what is the patient profile for choosing COCs containing like 35, 30 and 20 microgram ethinyl estradiol? It is always advised that in adolescent, we should start with low dose ethinyl estradiol, that is 20 microgram. The patient's profile should be like, she should not be prone for venous thromboembolism or myocardial infarction or cancer, etc. So norethindrone and norgestrel and levonorgestrel have low DVT risk, and desogestrel, drospirenone may have some risk. So at least for a year or even longer, a patient can take OCPs. The commonest complaint after taking OCPs will be hypertension in few, like 10 mm rise of blood pressure, which will settle down once the drug is withdrawn. Weight gain is not the complication with low dose COCs, and acne. In fact, OCP is the treatment. We prefer pill with anti-androgens with progestational activity, example, cyproterone acetate pill. So in research, situation like insulin resistance is seen in good 60 to 65 patients, percentage of the patients. Clinically, it is seen in 20 to 25% obese PCOS and 5% in lean PCOS patients. These are the findings in insulin resistance like acanthosis nigricans and skin tags. So up to 40% of women with PCOS have impaired glucose tolerance. Risk of IGT and type 2 diabetes mellitus is increased in both obese and non-obese women with PCOS. Retrospective studies have shown that 2 to 5-fold increase of type 2 diabetes mellitus in women with PCOS. Are insulin sensitizers prescribed to all women with PCOS or only with insulin resistance? Recent guidelines say insulin sensitizers like metformin is used in patients with impaired glucose tolerance, patients and not otherwise. The use of metformin in PCOS should be restricted to those patients with glucose intolerance. The Escher guideline says this, and metformin may be added to clomiphene citrate in women with clomiphene resistance who are older and have visceral obesity. 4 minutes. So metformin, is it metformin or myoinositol? So metformin could be considered in adolescents at risk of or with PCOS for cycle regulation or acknowledging limited evidence. And myoinositol, very limited quality evidence, but in use because they are with potential benefits and without evidence of harm. If the patient gets conceived when she is already on metformin, she is advised to continue. And once she is on like COCs and she wants to plan for pregnancy, we have to stop COCs and give ovarian stimulation. What is the line of treatment in women with PCOS who have conceived naturally? Yes, it's already said like patients have high chances of miscarriages, so they need to be put on micronized vaginal progesterones. So the complications are like short-term complications, obesity, infertility, irregular menses, abnormal lipid levels, hirsutism, acne, androgenic alopecia, glucose intolerance, acanthosis nigricans. Long-term consequences will be diabetes mellitus, endometrial cancer, cardiovascular diseases. This is a flow chart. So we have to counsel the patient. She may be prone for infertility and has to be screened periodically for diabetes, cardiovascular diseases, and endometrial cancers. So coming to the PCOS and infertility, the main aim will be like we have to have an ideal outcome of single live birth at term to minimize complication of cycle cancellation, multiple pregnancy, and OHS. So letrozole should be used rather than clomiphene citrate in women with PCOS with anovulatory infertility. The second line management is laparoscopic ovarian drilling, which should not be done for adolescent PCOS. This is based on the international evidence-based guidelines for the assessment and management of PCOS by Fisher. This about OHS. So in adolescent, we do not recommend ovarian drilling only unless and until this patient has come for infertility problems.
I think you have exceeded your time, Dr. Danya.
Okay.
Thank you. Judges,
Thank you, Dr. Danya. Okay, in the differential diagnosis of PCOD, you can also keep ovarian hypertrichosis. What is ovarian hypertrichosis?
I don't have no idea, ma'am.
Okay, doesn't matter. Okay, there is one more question. Okay, you said you will do DHEAS, okay, for the differentials of PCOS. So what is the role of doing DHEAS? How does it help in DHEAS? What type of predictions you are making on the basis of doing a dehydroepiandrosterone sulfate? What is the origin of DHEAS? Is it ovary or it is adrenal? Where does it come from? So which tumor it will predict?
Cushing's.
Yeah, Cushing's is one of the DD. Another DD you said no, ovarian and adrenal tumors.
Yes, ma'am.
Okay, so how do we rule out these?
Congenital adrenal hyperplasia.
Yeah, that is one of the DDs. Other DDs? Okay, no issues. Ma'am, you want to ask something, ma'am?
So we were talking mainly, the focus is on adolescent PCOS, no? So if an adolescent girl comes with such symptoms, how long should you actually wait to pronounce a diagnosis of PCO? Probably in a teenage girl who's, recently attained menarche. Yeah.
We have to wait at least for 2 years for the cycle to settle down. For the ovarian cycle to settle down, then we have to rule out PCOS now.
Yeah. Yes. So a minimum of 2 years before you pronounce. What is actually the best option to pick up the polycystic ovarian morphology?
USG.
Yes, USG. In USG only.
At least there should be 8 to 12 follicles, each having about 2 to 9 mm size and a volume of more than 10 cc.
Yeah, yeah. And the route of your ultrasound?
Transabdominal, ma'am. TVS is more better.
Yes, yeah. Yes. TVS is actually the ideal, and that is what's recommended.
Yes, ma'am.
But when you're looking at young girls, maybe. Yes. Yeah. Okay, ma'am. Thank you. It was quite an extensive presentation. Thank you.
Thank you. Thank you.
Thank you, Dr. Nidhi Sharma and Dr. Vijay Lakshmi, for the continuous support.
Thank you, ma'am.
Thank you. Thank you, madam.
Thank you so much. Dr. Radhika?
Thank you, madam.
Yes.
It was an interesting session. We are moving on to the next scientific session. I invite Dr. Shanti, madam, who is a professor and HOD of OG Department, Government Theni Medical College. And she's also the president of OG Society Theni and South Zone Coordinator, Medical Disorder of Pregnancy Committee, FOGC. And she's received Best Doctor IMA Award, and she's a Best Service Provider Award for PPIUCD and lab sterilization. Her special interests are high-risk obstetrics. Welcome, madam.
Thank you, madam. Thank you, madam.
I invite Dr. Supriya Jaiswal, madam, who is Vice President of Patna Obstetric Gynecological Society.
Radhika, 1 minute. Dr. Shanti will introduce Dr. Supriya.
Okay, ma'am. Dr. Shanti
Thank you,
ma'am,
madam.
please.
Thank you, Radhika ma'am. Thank you,
Thank
Sampath
you,
ma'am
ma'am.
and Revati madam for the opportunity to share the stage with my teacher, Cynthia ma'am,
Yes, ma'am.
and also Bhaskar Pal sir.
Yeah.
Thank you, madam. And it's a great privilege to introduce Dr. Supriya Jaiswal, who is a good friend of mine. And she is the chairperson of Adolescent Health Committee of FOXY present. And she is also vice president of Patna Obstetric and Gynec Society. She is very much known for her activities for adolescent. And she is a joint secretary of SOVI. And she is a chief consultant in SM Hospital Patna, executive member of ISOBAB, and executive member of HISAR Bihar chapter, executive member of IAG Patna chapter. She is trained in colposcopy and awarded with Dr. MP John and Dr. GV Helen Murthy Award for best short paper in obstetrics. Over to you, madam, for your topic menstrual hygiene.
Thank you so much, Shanti madam, for your lovely words. First of all, I would really thank the TNFOG team for inviting me and giving me this opportunity to talk on this important topic in your such an important adolescent marathon program. So the program name itself is so nice, TNFOG Marathon CME on adolescents, all about adolescents. And being the chairperson of Adolescent Health, I'm very much happy that the dear Dr. Sampath Kumari madam has given me this opportunity, and the Revati madam and all of you who are present here. So I'd like to share my screen here.
Welcome, Supriya.
Thank you, madam. Can you see my ear? Can you see, madam?
Yes, ma'am.
Madam. Yes, madam.
Yeah. Yes. So once again, a very good evening to everyone and all the viewers who are present here. I would love to talk on this very important subject, that is menstrual hygiene and its significance. So menstruation is a natural process that occurs in the female reproductive system that everybody knows. It is a crucial aspect of a woman's life, and it is important to maintain good menstrual hygiene during this time. Menstrual hygiene refers to the practice of keeping yourself clean and hygienic during menstruation. Periods are tough, but we can make it simple by just maintaining a hygiene. Poor menstrual hygiene can lead to various health issues like infections and diseases. Therefore, it is important to understand the significance of menstrual hygiene and adopt good practices. Menstruation is a natural process and in which the lining of the uterus sheds every month, leading to vaginal bleeding. It is also a crucial aspect of reproductive health, and it is important to understand the process and its significance. Menstruation lasts for an average of 3 to 5 days, and it occurs once every 28 days. So maintaining good menstrual hygiene is essential.
It was a competition,
For
basically.
staying healthy and avoiding
Priya,
disease.
1 minute.
No,
Others, please mute. Others can unmute. Sahiti, unmute others.
So poor menstrual hygiene can lead to various infections like bacterial vaginosis, urinary tract infections, and urinary tract infections and yeast infections. It can also cause skin irritation, rashes, and bad odor. Hence, it is important to adopt good menstrual hygiene practices like using sanitary products, changing them frequently, and washing the genital area regularly. Menstrual hygiene practices are affected by cultural norms, and these parental influences, personal preferences, economic status, and socioeconomic pressures. Menstrual belief refers to misconception and attitudes towards menstruation within a given culture or religion. Menstrual beliefs, knowledge, and practices are all interrelated. Menstrual hygiene management. So, there are several menstrual hygiene products available in the market, including sanitary pads, tampons, menstrual cups, and period panties. It is important to choose the right product based on personal preference, comfort, and hygiene. Sanitary pads are the most commonly used products since years and are available in different sizes and varieties. Tampons are also popular but require proper insertion and removal techniques. Menstrual cups and period panties are eco-friendly alternatives that can be used for longer hours, and they are very well accepted by people now. How to insert a menstrual cup, everybody knows. I will not go much into the detail, but then you should remember the C fold. This fold is the most well-known, but it may still be too wide to insert for some. If so, try the additional folds below. So punch down fold, then the 7 fold. These are the pictures you can get on any website or network on the internet, and you learn it, and it is very simple to use once you know the technique. So this is the technique. You can see you have to, so here it is important to wash your hands, fold the cup into a C shape, gently insert into your vagina, and wear for up to 12 hours. So menstrual cups are being very, very widely accepted, and we also promote the menstrual cups these days. Menstrual hygiene management refers to the proper disposal of menstrual waste. It is important to dispose of used sanitary products properly to avoid environmental pollution and the spread of diseases. Sanitary waste should be wrapped in a paper or plastic bag and disposed of in a designated bin. It is also important to wash hands thoroughly after changing sanitary products. Menstruation is often associated with myths and taboos in many societies. Women are considered impure during the periods and are not allowed to enter places of worship or touch certain objects. Such beliefs are baseless and can lead to discrimination and stigma. So let us break this taboo. So these were the certain things that a graph is showing that wash hair on the 4th day, and these old beliefs that people used to follow. So breaking the taboo is very important. We need to educate people and create awareness about menstrual hygiene to dispel such myths. So 28th May, like every year, we celebrate this menstrual hygiene day. So from powerless to empowerment, menstruation is a natural thing and you should be proud of it. So we need to break this taboo. The latest guidelines for menstrual hygiene management are provided by the World Health Organization and the Ministry of Health and Family Welfare, Government of India. These guidelines aim to provide a framework for menstrual hygiene management and promote good practices. Some of the key guidelines are use of sanitary products. Women should use sanitary products like pads, tampons, menstrual cups that are very eco-friendly, or period panties, even cloths during menstruation. These products should be changed every 4 to 6 hours to maintain hygiene. Proper disposal of sanitary waste, as we said, sanitary waste should be disposed of properly to avoid environmental pollution. And I think everybody should be aware of this. Used sanitary products should be wrapped in it should not directly thrown in the dustbin. It should be wrapped in a paper or plastic bags, and then it should be disposed. Then personal hygiene. Women should maintain personal hygiene during menstruation by washing the genital area with soap and water at least twice a day. Education is very important. Women should be educated about menstruation and menstrual hygiene to dispel myths and promote good practices. This can be done through health education programs in schools and community outreach programs. WHO calls for menstrual health to be recognized, framed, and addressed as a health and human right issue, not a hygiene issue only. WHO calls for these 3 actions, like firstly, to recognize and frame menstruation as a health issue, not a hygiene issue only. A health issue with physical, psychological, and social dimensions, and one that needs to be addressed in the perspective of a life course from before menarche to after menopause. Secondly, to recognize that menstrual health means that women and girls have access to information and education about it, the menstrual products that they need, water, sanitation and disposal facilities, competent and empathic care when needed, live study and work in an environment in which menstruation is seen as positive and healthy, not something to be ashamed of, and to fully participate in work and social activities. Thirdly, to ensure that these activities are included in the relevant sectoral work plans and budgets. and their performances is measured time to time. WHO also recognizes that several sectors have equally important roles to play in promoting and safeguarding menstrual health. They are committed to stepping up its efforts to encourage health policy makers and program managers to engage with these sectors to promote the rights of women, girls, and other people who menstruate and meet their comprehensive menstrual health needs. WHO is also committed to breaking the silence and stigma associated with menstruation and to make schools, health facilities, and other workplaces menstruation responsive. The government has a crucial role to play in promoting menstrual hygiene management. The government can provide access to affordable and quality menstrual hygiene products, create awareness about menstrual hygiene through education and health programs, ensure proper disposal of sanitary waste by providing designated bins and waste management systems, provide access to clean water and sanitation facilities to maintain personal hygiene. In India, the government has launched several initiatives to promote menstrual hygiene management, such as the Swachh Bharat Abhiyan and the Menstrual Hygiene Scheme. These initiatives aim to provide access to menstrual hygiene products and create awareness about menstrual hygiene among women and girls. So menstrual hygiene management is not just about sanitation. It is a vital step towards protecting the girl child while safeguarding her dignity and giving her a life of opportunities to pursue her dreams towards achieving a gender-balanced world. To address this vital aspect, MHM has been included as an important component in the government's flagship program, the Swachh Bharat Mission Gramin. It underlines the need for construction of toilets in households and schools, which is integral to menstrual hygiene and encourages safe menstrual hygiene practices. It further calls for skill development and setting up of sanitary napkin dispensers and incinerators in schools and public toilets. In keeping with this, states have initiated various programs that have dispelled myths and taboos surrounding menstruation, encouraging girls and women to talk about it and clarify their doubts. The major objectives of the scheme are to increase awareness among adolescent girls on menstrual hygiene, to increase access to the use of high-quality sanitary napkins to adolescent girls in rural areas, especially to ensure safe disposal of sanitary napkins in an environmental-friendly manner. The scheme was initially implemented in 2011 in 17 states, wherein a pack of 6 sanitary napkins called Free Days was provided to rural adolescent girls for ₹6 only. From 2014 onwards, funds are now being provided to states, UTS, under National Health Mission and decentralized procurement of sanitary napkins to other adolescent girls. The ASHA workers will continue to be responsible for distributing these for just ₹1 per pack sold and a free pack of napkin every month for our own personal use. They had to convene monthly meetings at the Anganwadi centers or other such platforms for adolescent girls to focus on issues of menstrual hygiene and also serve as a platform to discuss other relevant SRH issues. A range of IEC material had been developed around MHS using a 360-degree approach to create awareness among adolescent girls about safe and hygienic menstrual hygiene health practices, which includes audio, video, and reading materials for adolescent girls and job aids for ASHAs and other field-level functionaries for communicating with the adolescent girls. So ABCDEF of this is awareness and acceptability regarding sanitary napkins, role of teachers, role of family, better ways, ideas of disposing menstrual waste, quality and supply of sanitary napkins, and role of healthcare providers. So as there are many myths and misconceptions regarding menstruation, the provision of education on menstruation and reproductive health, particularly in rural schools, is still a major concern as the teachers themselves are not scientifically oriented towards menstrual health issues. In small villages of India, the government school have 3 or 4 teachers most of the time. 1 or the 2 teachers are busy in implementing government programs like census data collection, pulse polio immunization like this. So hence the schools are left only with few teachers, and so this is a neglected issue. Elderly women in Indian families, particularly the grandmothers, are often the ultimate decision makers of the household, and most of the time they have their own cultural prejudices. It is essential that all women in the family become educated and are counseled on the importance of use of sanitary napkins. Incinerators installed in the toilet for easy sanitary product disposal. Then incinerators used to dispose of menstrual in rural areas of India. These were that were used previously. So always people know that they have to do the proper thing. The recommendation of the new proposed scheme is to promote the local production of sanitary napkins by self-help groups. This will generate local employment opportunities and ensure community participation. However, there are questions related to sterilization and quality of the napkins themselves. Development of a quality control mechanism should be in place to keep surveillance over the quality of sanitary napkins or menstrual cups. Very little attention is given to the topic of menstrual hygiene in medical curriculum. Not a single chapter on this important topic is included in standard textbooks read by the Indian undergraduate medical students. This clearly reflects in their medical practice, where this issue of menstrual hygiene is treated very lightly. So there are many ways. These are the books. What is menstrual hygiene? There are many. These days, the awareness has increased. Like Nukkad Natak is a street play that is performed in public places to create awareness about these social issues. Other than that, pamphlets are an effective way to educate people about menstrual hygiene. What creates the menstrual crisis? No taboos. What can we do about this? So such things people take interest and read, and slogans really help because they are short and catchy phrases that can create awareness about menstrual hygiene. It's like keep calm and change your pad. Periods are normal. Let's talk about them. Don't hide. Speak up about menstrual hygiene. So these little small slogans really help for the awareness programs. Then the banners can be hung in public places to create awareness. Animations can be used to create engaging and informative content about this menstrual hygiene. Movies creating awareness like Padman and the famous Akshay Kumar doing this. So these things really, a movie about periods wins the Oscar. It was really so applauding about it because these things can catch the public's attention. So menstrual hygiene day celebration is another one, 28th May menstrual hygiene day, when everybody, all of us, even the public, these are just a few examples of menstrual hygiene awareness programs for adolescents. There are many more creative ways to create awareness about menstrual hygiene and promote good practices. So menstrual hygiene is an important aspect of reproductive health that needs to be addressed properly. Maintaining good menstrual hygiene practices can prevent various health issues and infections. It is important to choose the right menstrual hygiene product, particularly, and practice proper disposal methods and educate people about menstrual hygiene to break the stigma associated with it. By adopting good menstrual hygiene practices, women can stay healthy and lead a comfortable life. To effectively manage their menstruation, girls and women require access to, as we said, water, sanitation, and hygiene. It looks like it is simple, but it is very, very important. Then they need access to the affordable and appropriate menstrual hygiene material, information on good practices, and a supportive environment where they can manage menstruation without being embarrassed or stigmatized. So thank you very much. Together, we can empower all women and girls to realize their full potential. So let us all celebrate Menstrual Hygiene Day every day, and let us make aware all our adolescents and the public so that menstruation can be taken up very nicely and public can be aware of that. So menstrual hygiene is very, very important. Thank you very much for the patient listening.
Thank you, Supriya, for the wonderful talk. Yes, as all of us know, the menstrual hygiene day, that is on May 28th, 5th month 28. Once in 28 days, bleeding for 4 to 5 days. That indicates 28/5. Anyway, the adolescent, and as adolescent, we have to talk to them about cloths also, homemade cloths. If they are not comfortable with menstrual hygiene, rather than the pad, homemade cloths also. Wonderful talk, Supriya. So you have justified your talk. Thank you so much.
Thank you, madam.
Now we have our twin sisters, Dr. Jayamala and Dr. Shanmugavadivu for our panel. Both of them have matched, I think, with the dress also. You can have the wonderful talk. Dr. Radhika, can you introduce?
Yes, ma'am. Yes, ma'am. Thank you, ma'am.
Supriya, if any doubt, you can answer in the chat box. Okay.
Yes, madam. Yes, I'm there.
Thank you, Supriya.
Thank you, madam.
Thank you, Sampath ma'am. Thank you, Supriya ma'am. Wonderful session. Now moving on to session 3, panel discussion on ovarian masses in adolescents, adnexal mass in adolescents. I invite Dr. G. Jayamala, who is a consultant obstetrician and gynecologist, infertility specialist and laparoscopic surgeon. And she's the managing director of Rainbow Hospital for Women and Children and president of OG Society of Salem.
Thank you.
Welcome, Dr. Jayamala. And I invite Dr. Professor L. Shanmugavadivu, Secretary and Obs and Gynae Society of Salem. She is a professor, Department of OG, Government Mohan Kumaramangalam Medical College Hospital, Salem. She has 16 years of excellent service to our medical field, untiring teaching experience for both undergraduates and postgraduates. And she's published indigenous articles in national and international journals. Her special interest in the field of high-risk obstetrics and endoscopy. Welcome, Dr. Shanmugavadivu.
Jayamala, do you want to introduce the panelist or Radhika will introduce?
Radhika, ma'am. We don't have the PPT slides, so.
Radhika, you can introduce the panelist of this Jayamala and Shanmugavadivu has got the Durusha Trophy Award. That is mainly for adolescent this year in Foxy.
Thank you so much.
Okay.
Thank you.
Congratulations.
Radhika introduced that panelist. Uma Brinda is not there, I think. Now I saw it.
She's not there. She's gone. I invite Dr. N. Saravakumar for the panel discussion. He is a professor in HOD, Department of Obs and Gynae.
Saravakumar is expert. First, you are introducing him.
Annapurna Medical College. And he is an MBBS. He's done his MBBS from Bellary, WIMS Bellary, and MD from MMC Chennai. He is a secretary, OG Society, Salem, Tamil Nadu, and organizing secretary, Foxy South Zone Conference with UR 2022, and is consultant at Mallar Maternity Hospital. And he has initiated and trained young gynecologists in operative laparoscopy in Annapurna Medical College. His field of interest is in high-risk obs and gynae and endoscopy. Welcome, sir.
Yes, hey, Radhika, go. The next panelist is Dr. Radhika, who is our MOC. She has done her DJO in Tanjore and MSUG in UK, 10 years NHS UK experience as registrar, member of Foxy, Oxy and Tirunelveli Society. And her field of interest is adolescent and high-risk pregnancy. Okay, Radhika.
Thank you, ma'am. Thank you for your kind words. Madam, I invite Dr. Leena Dhruv, who has done her MBBS from Government Medical College, Nagpur, Maharashtra, and MS Obs and Gynae, BJMC, Ahmedabad, Gujarat. And she's worked as assistant professor in Government Medical College, Nagpur. Currently, she's working as assistant professor in SMM CHRI, Chennai. And I invite Dr. Swati from she's done her MBBS from Karpaga Vinayagar Institute of Medical Science and her MSOG from KVG Medical College, and she's a university rank holder. And she's currently working in Sri Muthukumaran Medical College as assistant professor. And her publications are, she has numerous publications, and the main one is the knowledge and attitude practices towards PCOS among medical students in South Karnataka, which is very relevant to this topic. And she has also done a publication on assessment of cervical length by TVS during second trimester and its perinatal outcomes. Welcome, Dr. Swati.
Jayamala, I think 4 of them are there. Radhika,
Yes,
Swati,
Yes, ma'am.
Uma Brinda is not
That
there.
I know.
Okay.
You can proceed.
Sure.
Thank you.
Right. Share it. Yes. Good evening, ma'am. Thanks for the opportunity. I know it's a short notice. We have tried our best. And I welcome all our panelists for a for the scientific session. Let us have a practical discussion today. So as we are all aware, adnexal lesion in adolescent comprises ovarian or tubal pathology or both. It's commonly benign. It's less than 10% is malignant, and malignancy, ovarian malignancy constitutes 1% of childhood cancer. So I just want to emphasize today, this adolescent ovarian pathology should be dealt properly, and when we operate on it, we should always think about their future, think about ovarian preservation, because recently I had a discussion with one of my colleagues who's from a government setup, sorry to say that, but she said ovarian cyst, any ovarian cyst, even if she's an adolescent or unmarried girl, we just go for laparotomy and then we remove the ovary. My heart stopped for a minute because I thought laparotomy per se is a crime, and hysterectomy for just a simple ovarian cyst is really a grave crime. So let us move on to management of adolescent mass. Let Dr. Shanmugam start with our first case.
So adolescent pelvic mass can be asymptomatic, or it can be present as chronic mass or with acute symptoms, or maybe discovered instantly when you are doing ultrasound for evaluation of the urinary system or to evaluate some other pelvic pain. And the mere presence of mass on imaging studies does not always indicate the mass is the cause of pelvic pain. And ovarian mass can present as acute, severe, intermittent symptoms can be caused by torsion, any intraperitoneal rupture, or bleeding into the ovarian tissue, or it may present as pressure symptoms. And main thing is the history and pelvic examination is very important in diagnosis of the pelvic mass. And also you should consider about the adolescent anxiety and also issues regarding the confidentiality regarding the sexual activity. And also always rule out causes of pregnancy, because it may be also a cause. And also do a complete blood count, which may be useful in diagnosis. We go for the tumor mark later, and the basic modality is ultrasound. And if doubt arises, we can go for CT or MRI. And accurate pre-op, when you doubt any Mullerian anomalies, MRI will be a better diagnosis. We'll come to the case one. Case one, she is a 17-year-old single female as presented to our emergency room complaining of generalized abdominal pain for 2 weeks. And the pain is colicky in nature, progressive intensity with no issue of fever, nausea, or vomiting, or changes in bowel habit. And she did not notice any abdominal distension changes in, but she complained of dysuria for 2 weeks. And she attained menarche 5 years ago with a regular menstrual cycle and vitals are normal. Examination of a palpable pelvic abdominal mass about 14 week size, which is non-tender, mobile, and with no skin changes on abdominal examination. And Dr. Saravanan sir, what will be the probable differential diagnosis for this adnexal mass?
This mass is something which is not tender, and probably it can be a uterine mass. And one thing is we have to rule out pregnancy in these patients who just can't come with undiagnosed pregnancies. And once we rule out pregnancies, then probably we can go in for the other differential diagnosis. Can be a uterine mass and can be a fibroid also. But at the same time, the other adnexal pathology cannot be completely ruled out. So here the examination findings may not give us a proper picture. So subjecting these patients to an ultrasound can give us the other differential diagnosis like ovarian cyst. It can be a huge ovarian cyst or
not audible, sir.
Not audible. Okay. So it can be a huge ovarian cyst also. But and can be an, usually endometriotic cysts will not come to this big extent. Dermoid cyst can also be a differential diagnosis. So these are the things which has to be considered. Hello.
So when you come to different diagnosis or mass arising from the fungal benign, inflammatory mass can be in mass, and from ovarian cyst can also be there. So intrauterine pregnancy or pregnancy in bicornate uterus in the horn, and also any related to other organs also. It may be mass arising from bowel, mesentery, or it may be from the urethral, or it may be even a pelvic kidney. So this will be the differential diagnosis, and we will discuss this one later. This case, an ultrasound revealed a mass of ovarian cyst of about 6.3 into 7.3 and 5.6 into 6.3 on the right side, and left side cystic ovarian cyst of about 12.5 into 7.8 centimeter with projections in the cavity. So how about we classify the benign and ovarian cyst? Dr. Radhika?
Yes,
in ultrasound, how we differentiate between a benign and ovarian cyst in ultrasound?
Yeah, we have to use IOAT, IOTA classification. And depending on the solid area, size of the tumor, the solid areas, papillary excrescences, we have to score the features, and based on that, and we have to multiply it with the CA125, the tumor marker, and decide on the whether it is, correlate and find out if it is malignant or benign.
Okay, well said, Radhika. So the benign cyst, usually it will be a unilocular cyst and it will not be having any solid component, and there will be presence of acoustic shadowing, and the tumor size will be, if it is multilocular also, it will be less than 10 centimeter. There will not be any vascularity will not be there. And the malignant one, it will be irregular solid tumor, ascites will be there, and papillary structures will be there. And also the tumor size will be more than 10 centimeter, and mass will be irregular and multilocular, and it will be more vascular. So you want to heavily investigate further, Dr. Leena? Dr. Leena?
Am I audible?
You want to add on investigations to this, Dr. Leena, apart from this ultrasound?
You can go for tumor markers for this patient, beta HCG, LDH, alpha fetoprotein and all, to see whether the tumor markers correlate with it, to help us in diagnosis whether it is benign or malignant.
Okay, thank you, Dr. Leena. So we can on with CT or MRI abdomen pelvis, and also with the markers as said by Dr. Leena. Then for this, if the diagnosis, all these tumor markers are negative, and also the MRI picture suggestive of benign mass. So how will you approach this case, Dr. Swati? What do you want to do for this patient? Dr. Swati, are you there? Swati? Anybody else can take up this question?
I'm just trying to find out another way to do this. Okay, so a benign mass of this nature when we think of just as an ovarian mass, we can first, once we are sure that the tumor markers are not raised and it's a benign mass, this is a large mass which has to be dealt with the surgery. So I would prefer to do a laparoscopy for this patient to see the nature of the mass, and also preferably if there is any frozen section, I would also involve the frozen section for this patient. So I can do laparoscopy with the removal of the cyst and retain the ovaries.
Okay, sir. Thank you. So we will we do a laparoscopic ovarian cystectomy and preserve as much as ovarian tissue possible. So the algorithm for this benign any pelvic masses. So you do ultrasound, then you do you diagnose whether it is a mass is arising from ovary or in causes. Then you see whether it is a uniloculated or a multilocular cyst. So if it is a unilocular cyst, you observe for 2 to 3 months and the size is decreased, then you can just follow up. If it is a multilocular cyst, if it is a premenarcheal, that's very important. If it is a premenarcheal, always do a karyotyping to rule out any gonadoblastoma. So next, if it is a postmenarcheal, you can observe for 2 to 3 months, and adding up oral contraceptive pill is optional. If there is increase in size or the cyst is persistent, then you do markers. You do a AFP and beta HCG. But if the size is decreased, you can follow up. So if it is more than 8 to 10 centimeter, always you go for a surgery. And if it is a benign, you do a laparoscopic ovarian cystectomy with ovarian preservation. So this case has been dealt with the bilateral ovarian cystectomy with preservation of adequate normal ovarian tissue. So what complications you expect any benign pelvic mass, Dr. Radhika?
Hemorrhage, there can be hemorrhage and pain and infection of the cyst can rupture.
Okay.
And sometimes torsion is also a possibility. I think these are the main.
Okay, so to avoid all these complications, we have to go for surgery. So you, as you said, the most common complication is torsion, or it can be rupture, or sometimes if it is any dermoid cyst like that, it can go for malignant degeneration, and you can get superimposed infection. So all these larger cysts has to be dealt with surgery. So we'll move on to the next case.
Okay. So this is our second case. This is a 16-year-old girl who was presented with right-sided abdominal pain for past 2 days. There's no history of fever. She complains of nausea. Her LMP was 2 weeks ago. Her vitals are stable. Her abdomen is soft. There is right iliac fossa tenderness. There's no mass. There's no palpable mass because there's little bit of guarding is there. Okay, so this is the history she has presented. What could be the possible diagnosis in this case? Dr. Radhika?
First, it could be a ectopic pregnancy, or it could be also a torsion.
Good. Yeah, her LMP was 2 weeks ago.
2 weeks ago.
So
yes.
I presume yes, that doesn't rule out ectopic pregnancy. Yes,
absolutely.
That's a good thing that we will do a urine pregnancy test. Yeah.
Yes.
So yeah. So what else could be? I mean, we are thinking only in the line of gynecologists, right?
Yes. It could be appendicitis also, as you said.
Exactly.
And
yes.
PID, pelvic inflammatory disease.
Yes.
The other option is even a hemorrhagic cyst.
Yes, exactly.
Ovarian
and the other thing I told is 2 weeks. Her LMP was 2 weeks ago, so it could be an ovulatory pain also, right?
Absolutely.
Yeah.
Ovulatory pain,
It could be appendicitis, as you mentioned, torsion, ovarian cyst, ectopic, ovulatory pain, or as you said, PID or TO. Yes, good. So the ultrasound showed she had all the investigations. Okay, the blood investigations were normal. Ultrasound showed a right ovarian cyst, which was 6 to 7 centimeter with normal blood flow, ruling out torsion. So she was sent home as pain subsided after painkiller. But she came back 2 days later with pain. Now, what do you think? Dr. Leena?
Since it was a unilateral increased size of the ovarian cyst, and once the pain was subsided, and again she had pain, so most likely this could be a case of torsion. Because the patient is having intermittent pain time and again.
So, yeah, very good. Then what are the ultrasound findings that is suggestive of ovarian torsion?
Usually enlarged unilateral cyst with peripherally organized follicles.
Excellent.
The blood supply is there, but that is not usually absent blood supply is not an indication that it is a torsion. And the presence of blood supply is there, so not a proper Doppler changes. It will say presence of blood supply can also be there in case of torsion.
Yes.
When the patient has initially come with some amount of guarding, that indicates that this benign cyst may be undergoing a sort of a torsion and detorsion, and we have to be very careful in sending the patient back, so that these patients may sometimes go for a complete torsion and may present later, because we have given her analgesics also. So these analgesics may sometimes mask the
rightly said, thickening of body, whirlpool sign, and absent Doppler flow. These could be the findings in a torsion ovarian cyst. So, as Dr. Saravanan said, the Doppler flow may be normal if the patient has partial torsion, transient torsion, or early in the torsion process. So, blood flow was present in 28.5% of surgically proven torsion. So, the decision to operate should not be based exclusively on ultrasound, especially only on Doppler. So, this is what I wanted to highlight here. So, yeah, so the patient was taken up for diagnostic lab with a suspicion of torsion ovarian cyst, and this is her picture. So, this is the picture. So, what to do? Dr. Swati?
Dr. Swati is not there.
Okay, being endoscopic surgeon, I think we move on to Dr. Saravanan.
Okay, with this picture, what I would do is just I would see the type of torsion that has happened. Just detort it. We will gain the color, and once it gains the color, then probably I would do a cystectomy. I think it is not a complete total black structure we see. It will definitely gain some amount of blood flow. And once I remove the benign cyst, I can hitch the ovaries to the pelvic side walls. Otherwise, I just leave behind, give a wash, and then close the wound.
So this, after you detort, it doesn't go back to the normal color immediately, right?
Yeah, it doesn't go back to the normal color. I just wait.
So you still have the same color. So what do you do?
Majority of the torsion will gain blood supply. I think unless until it is totally black and it is bleeding, then only then I will have to remove that portion of the ovary. Otherwise, I will just leave behind. Most of the ovaries I've left behind, and they have recovered very well.
Excellent. Yeah. So this is what I wanted to highlight here. Yeah. So as he rightly said, either you detort with or without cystectomy, despite necrotic appearance of the ovary. So you sometimes can do detortion and do cystectomy at the same time, or you can just detort, leave it, and come back next time for cystectomy, or most of the times it disappears on its own also. See, the other thing is it is fully edematous. You can just do multiple punctures and do a cyst drainage. As Dr. Saravanan said, ovarian necrosis, ovary that is dark and enlarged with or without hemorrhagic lesion is most likely still viable. With appearance is because of the vascular and lymphatic compromise, and it's not due to necrosis. So, however bad looking it is, unless when you hold the ovarian cyst, it becomes necrotic and it comes off, otherwise you can just leave every ovarian cyst, a torted ovary. So, Dr. Saravanan, what are the surgical techniques to prevent recurrence?
Yes, to prevent recurrence, I would just hitch the ovary to one of the pelvic side walls. But the only thing is, if it's a very enlarged ovary and it is very friable, it is not possible at that particular time. And
Yes.
Otherwise, that will do.
So do you always do?
No, I don't do it always. I don't do it always. If it's a small ovary and the tubes are all the tubes are not very much enlarged, so then probably we can just leave it again, leave it without doing anything.
So when do you decide to, do this oophoropexy? What will be the indications?
If it's I mean, if the ovaries are enlarged and it is twisted to 2 or 3 twists, so these are the patients with a very long pedicle. So those are the conditions where I just want a very long pedicle, in the sense the ovarian ligament. If it's too long, then probably these are the patients who may go for a repeat torsion. Those are the ones who need ditching.
Yeah, but would you go with the number of twists? Even if it is long, you can twist only once, right?
Yeah, you can twist it.
Yeah, right. Yeah, so as you rightly mentioned, the indications will be previous oophorectomy or absent ovary, and you have only one ovary left, right? So if this patient has a torsion, maybe the recurrence rate, or you don't want to lose that ovary also. So if somebody had a previous oophorectomy and she had torsion, yes, we would like to do oophoropexy. And sometimes these, especially in this adolescent girls, torsion with normal ovary can happen. So that kind of patients, like we would like to do oophoropexy. And if, as you mentioned, if the ligamentous laxity, if you find that the ligament is too long intraoperatively, we can choose to do oophoropexy. See, the other techniques to do oophoropexy, or you can fix the ovary to pelvic side wall or posterior abdominal wall, posterior wall of uterus, uterosacral ligament. You can shorten the uterovarian ligament, or you can do combination techniques. And the recent one is the hot dog in bun technique, where the round ligament and uterovarian ligament act as one, and the fallopian tube as the hot dog. So these are the techniques that we can do to prevent recurrence. So this is one of the very ugly looking tarted ovary. So as you could see in that picture, it looks as though it is non-viable, it is gangrenous looking, very angry looking. But after you just incise it and drained all these, and this is the second look, a laparoscopy picture, where you can see the ovary almost looks near normal, right? So I think any ovary, unless it is very friable, it falls off as you touch. These are the ones that is necrotic. Otherwise, you can leave almost every ovary. Yeah. So these have shown that they gain their AMH levels, AFC counts, and everything even after 6 months. So thank you. Yeah, that was a good discussion on ovarian torsion. Let's move on to this case. Case third is an 18-year-old who presented with, again, right-sided lower abdominal pain for past 2 days. This complains of fever, nausea, discharge PV, and her LMP was 2 weeks ago. Her temperature is 101. Abdomen is soft. There's lower abdomen tenderness. And the investigations report, the blood test showed leukocytosis and increased CRP and ESR. So, what is the possible diagnosis in this patient, Dr. Leena?
Dr. Leena?
This can also be a case of ovarian torsion with necrotic changes. Am I audible?
Yeah, that's possible, yes. There's a reason why we had put in a discharge PV and all, right?
Possibly ovarian torsion only.
Okay.
Appendicitis, pelvic inflammatory disease.
I think
PID with
adolescent, all these abdomen
mass, tubovarian mass with abscess.
Yeah. Any acute abdomen, all these women, they can fit into all these 5 differential diagnoses, right? So, Yeah. So this case could be a pelvic inflammatory disease, as someone was prompting. Yeah. Okay. As we know, it is a polymicrobial infection. Okay. What are the tests you do for PID patients? Dr. Leena? Okay. Dr. Radhika?
Yes, we have to test the woman. First, again, we have to start with the urine pregnancy test, as in any other woman. And then the complete blood count, CRP. And before starting antibiotics, we need to know the renal function test as well. And high vaginal swab is a must for culture and sensitivity. We also have to check the partners, if she's married or if she's sexually active, we have to check the partner's bloods as well. And triple H to rule out HIV, hepatitis B and hepatitis C, and VDRL to rule out these sexually transmitted diseases. And so we have to do these tests. And apart from this, ultrasound abdomen and pelvis should be done. And
yeah, what are the possible causes for PID?
Gonococcus.
Very good.
Chlamydia.
Yes.
And even normal other bacteria like Streptococcus, Staphylococcus also can cause. And tuberculosis is also the the common pathogen.
Okay. So do we do any special test for chlamydia, gonorrhea? Do we routinely do it, Dr.
We don't. Yeah, we don't do it here, but we used to do in UK. Chlamydia
yeah, I
PCR.
saw your TV. That's why I asked you.
Yeah, we do a special, chlamydia PCR there.
Yeah, we do.
Anyway, we are covering the antibiotics here, so it is costly. So I think that's why
we should have a very high suspicion of PID, especially when adolescents come with these sort of symptoms, because if you miss to diagnose, they may go in for other complications, especially tubal damage.
Yeah, I think we do. Yeah, we don't need solid evidence that she has PID. Once we are suspicious of PID, I think it's better to treat her thinking about her future fertility.
Absolutely.
Good. So, what are all the treatment regimens for PID? How do we treat? Dr. Leena said.
We can treat her on OPD basis initially, cefoxitin or cefotaxime, oral, along with doxycycline. We can give 100 BD for 14 days to this patient.
Okay. So if it is a bit serious.
Fever and adolescent.
Adolescent PID is one condition where the patients may require an inpatient. They may be very irregular on treatment and they may miss the treatment also. So that is why the classic teaching is adolescent PID, admit them and
admit.
Okay. So what do you give to Saran Kumar?
Actually, the CDC gives a lot of guidelines about the CDC guideline, regimen A and regimen B. So though for an inpatient treatment, we can start with ceftriaxone, 1 gram IV 12th hourly. Along with that, we can give doxycycline. We have to give doxycycline and metrozine. Only thing is, we have to give the treatment for almost 14 days so that they have a complete cure of the PID.
Yes, good. So how long will you keep her in when you are admitting her? So we have to treat for 14 days. How many days will you keep her admitted and give her IV?
Yeah, we'll give her IV till her symptoms are reduced, her temperature becomes normal, her counts have become normal, and then we can shift her to oral regime and send her home.
Very good, excellent. So you rightly said ceftriaxone 1 gram, doxycycline 100 milligram 12th hourly, and metronidazole 500 milligram 12th hourly. That's for 14 days. Yes, thank you. So, and there are so many regimens, as Dr. Saran Kumar said, there are intramuscular regimens also. Almost everything comprises of cephalosporins, doxycycline, metronidazole. So, the same, I mean, it's a different patient, the same history, and an ultrasound, this is what we found. So, what is the possible diagnosis, Dr. Radhika?
Hydrosulfings.
Yeah. So, yeah, it could be TO, mass, right? So in mass, it could be an abscess. I mean, it doesn't look like an abscess here. It looks like TO mass. So now, what investigations would you do?
Now the same investigations as well as TB for we have to investigate for tuberculosis.
Yes. So what are the investigations you do for tuberculosis?
We have to start with the chest X-ray.
Yes.
And we do a manto, but again, it's not specific. But we still do it, and then the ESR, and we can do a laparoscopy and send the fluid for
Excellent. Yeah, excellent. I think you have covered almost everything with CBC, ESR, manto, which is more than 10 millimeter, but it's not reliable. Chest X-ray, yeah, ultrasound we have already told, laparoscopy, and then take the biopsy from the peritoneal lesion or whatever lesion you find out, you can send that for AFP microscopy, culture, CB-NAT, PCR. Of course, you will see if the granuloma and histopathology. So these are the investigations you do, and yeah, it confirms tuberculosis. So what do we do next?
Start her on ATT.
Yes. Do you start on your own or do you refer the patient to?
Actually, we can start on our own.
Very good.
Now,
yeah,
we have to register her under that TB program, TB eradication program, and start her on ATT and regularly follow her with a weekly LFT for ATT toxicity. And if she develops jaundice or the bilirubin and the enzymes are raised, then we have to discuss with the thoracic medicine specialist, TB specialist, and we have to maybe alter the medications.
Okay. So what will be your regimen, Dr. Radhika?
Usually the rifampicin, INH, pyrazinamide, and ethambutol, and along with this streptomycin is also given.
Okay.
For 2 months, and then for the 4 months, next 4 months, it's the rifampicin and INH.
Okay. Actually, this is the recent CDC guideline says, but I do not see people using streptomycin.
Yes.
But we give rifampicin, INH, pyrazinamide, ethambutol,
yes.
and then rifampicin, INH, and ethambutol for 4 months.
Okay.
So this is the regimen we use. So thank you. I think that was excellent, discussion. We'll move on to the next case now.
So this is the last case. We'll discuss about another case of adnexal mass. And she's a 18-year-old patient with a lump abdomen since 6 months and chief complaint of pain in abdomen. And she has a history of significant weight loss. And also on appearance, she's pale, cachexic, and clinical examination shows 20-week size, hard mass arising from the pelvis, which is immobile. And abdominal and transvaginal sonography was suggestive of normal sized uterus and a heterogeneous large mass anterior to the uterus. So, Dr. Leena, how you want to proceed with this case?
The scan was done. I'd like to go for tumor markers and MRI for this patient. As this, with the clinical history, is suggestive of malignant tumor, malignant mass in the pelvis.
Yeah. The clinical features, things are appearance, cachexia, and immobile mass. It's suggestive of most probably malignancy. So we have a detailed history and detailed clinical examination, and added with the ultrasound and tumor markers, and we can add it with CT to know the extent of the disease, to know the stage of the disease. And then the history also, with the history, we can, what are the symptoms, that symptom index. So it's bloating or pressure in the abdomen and pelvic or abdominal pain, urgency, urinary urgency or frequency, and difficulty in eating or early satiety, and all these defecation problems, loss of weight, and more than 12 episodes of any of the above symptoms present for less than 1 year needs a thorough evaluation. And also you should ask about the family history of breast, ovarian, endometrial carcinoma. So the history is very important. And the clinical examination, apart from this abdominal mass and the palpation, you have to look for anemia and the lymphadenopathy and any other organomegaly, ascites, and rectal examination. So if it is unmarried girl, may not do a pelvic examination. Then what are the tumor markers you want to do, Dr. Radhika?
Oh, we have to think of germ cell tumors, which are common, but we have to do CA1 to 5, start from the CA1 to 5, HCG, AFP, alpha fetoprotein, and CEA for this patient.
Okay, so for epithelial mass, you can even if we have germ cell tumor is common. Even otherwise, you have to rule out the serous epithelial carcinoma. So you do a CA125, CEA, and CA99 to rule out the mucinous CA, and CA99 to rule out the mucinous cystadenocarcinoma. And you get LDH, alpha fetoprotein, and beta HCG to rule out germ cell tumors. So other investigations, this all for just for planning the surgery. So patient evaluation for surgery, you do a hematology, biochemistry, and then just cardiac evaluation, X-ray chest. And this bilateral mass, you have to rule out, if it is a bilateral mass, always better to do upper and lower GI endoscopy, even in any age group, because to rule out the secondary Krukenberg's tumor. So upper GI and the lower GI endoscopy. So the secondaries may be there from upper GI or lower GI tract. So you have to rule out that if it is a bilateral mass. And in this case, had in CT we had 12 into 10, 14.4 ovarian mass, and this uterus was normal with the multiple, and also you had subcentric lymph node in para-aortic and mesenteric region with mild ascites, and also with pleural effusion, and LDH and beta HCG are elevated. And this, based on this laboratory values and these findings, we provisionally we made a diagnosis of dysgeminoma. And so after the correction of anemia, then we did the laparotomy, and in laparotomy we did a right-sided salpingo-oophorectomy with the resection of the tumor mass with partial omentectomy and lymphadenectomy. And this pathological diagnosis was turned out to be a dysgeminoma. And this peritoneal washings was negative, and also there is no secondary deposits. So further, how you want to, after the surgery, how you want to follow up the patient? Dr. Saravanan sir?
Yes, so this patient has been diagnosed with the dysgerminoma, and we have left behind one more ovary for this patient so that she can complete her family. So she has to be under total follow-up. The initial follow-up can be done with the tumor markers and see that the tumor markers are not elevated at any point of time. We have to insist on this patient that once she completes her family, we have to remove the other ovary also. So that's why we need to keep her under constant supervision.
Yes. And
repeat CT.
So we have to do a post-operatively, you do follow up with CT, and also tumor markers you follow up, and chemotherapy as per the type of the tumor. So since it's most of the things, it's all this epithelial germ cell tumors, they are very chemosensitive, so they respond very well to the chemotherapy even in any stage. So the follow-up chemotherapy, apart from stage 1A and 1B, this is there is no peritoneal spilling or anything. We need not give chemotherapy. But from stage 1C disease, all these cases need a follow-up chemotherapy. So this chemotherapy, anybody want to comment? Dr. Radhika, Dr. Leena, what type of chemotherapy you want to give for this patient?
No, sorry, I haven't tried.
Okay.
We'll refer her to oncologist.
Okay, mostly the surgery is done by the surgical oncologist and the treatment is done by medical oncologist. So, but this one for if it is a germ cell tumor, this BEP regimen, that's bleomycin, etoposide, and cisplatin, they respond very well to this regimen. And also, if it is not, we can go for this vinblastine, bleomycin, and cisplatin regimen also, or vincristine, actinomycin, or cyclophosphamide regimen. But the commonly used regimen is the BEP regimen. So we give 4 cycles of BEP regimen. So I will finally conclude this management outline for this dysgeminomas. So if it is any unilateral disease, so if it is a unilateral disease, you just inspect the, you do a unilateral oophorectomy, inspect the contralateral ovary, and the surgical staging is performed. If there is no metastatic disease, you observe, and the physical examination should be done every 2 months for first 12 months. And CT scan should be done at 6 and 12 months. And if there is any documented occult disease, so if it is any peritoneal deposits or ascites is positive, in that situation, or any lymph node positive, then you give the BEP regimen for 4 cycles. And if there is any small focus in the contralateral ovary, so you resect the focus with ovarian preservation. You preserve the ovary, just resect the focus alone. And if the surgical, if your just surgical staging is not done, so you have done as a simple, you're not diagnosed prior, and only at the time of surgery, only post-operatively you get the diagnosis as dysgeminoma. In that case, only the CT or ultrasound should be done first 2 months. 2 months once for first 6 months, and every 3 months once for the next 6 months. And the second year, it should be done every 6 months. And if there is any cytological and histological evidence of relapse, then you go for this BEP regimen. And if it is metastatic disease, you do a unilateral salpingo-oophorectomy and remove any readily resectable masses. So even if there is any peritoneal deposits or omental deposits, you remove the deposits and you give the chemotherapy for 4 to 6 cycles. And you can, if there is any clinically, if there is any follow up with the CT and ultrasound, if there is any mass, recurrent mass, you can go for a second look laparoscopy. So this is the treatment algorithm for ovarian mass, and this is concluding one. So dysgeminoma, it's excellent. You have excellent response to chemotherapy and radiotherapy, and post-surgical clinical surveillance can be planned for the patient because the sterility and gonadal dysfunction is associated with pelvic radiotherapy. So you should mainly go for the chemotherapy. And patient education on compliance with the treatment plan is very, very important. They should come up for regular follow-up. And as Saravanan sir said, if the patient is nearing, most of the time the patient will be nearing their marriage age, or that if it is their 18 years or 19 years, advise them to get early marriage, let them complete the family. Then you better go for a complete surgery, that is bilateral salpingo-oophorectomy. And in a nutshell, the ovarian, benign and malignant ovarian tumors should be kept in the differential diagnosis panel in case of vague abdominal symptoms in adolescent. And gynecological cancers most commonly encountered in the adolescent age group belongs to the ovarian origin. And early diagnosis in early stages of ovarian malignancy pave way for fertility sparing surgeries and good prognosis in adolescent age group following chemotherapy. So we'll conclude with this. Happy International Day of Girl Child on October 11.
One last point, Shanmugadiva. If because these are adolescent girls who are about to get married, ovarian tissue freezing from the normal side before the treatment can be considered.
But for these patients, I think the
other ovary
is normal. We can leave it inside because the chemotherapy, once after the chemotherapy is over, they return their fertility.
Yeah, but still
there will not be any fertility issue.
Yeah,
That's
sometimes
something that we have to always think about. Yes, that should have been biopsied anyway. The other ovary should have been biopsied also. And yes, always fertility preservation should be in our mind. Not only just malignancy, any ovarian, surgery,
Adolescent, yes.
endometrioma, everything that I think we have to think about fertility sparing as well. So.
The freezing techniques are available these days, no? Ovarian tissue freezing. Before, maybe I don't know, because fertility specialists may throw light on that.
Yeah, I think it needs to be discussed beforehand with the patient.
Beforehand, yes.
Yeah, and anything we have to have a multidisciplinary team approach, right?
Absolutely.
So in that case, yes, we have to think about that.
I think all this prognosis depends on the grade of the tumor. I think I faced a case of dysgeminoma in pregnancy. And one case I left it, it was around 8 centimeter. Throughout the pregnancy, the size didn't increase. And at the time of cesarean section, I removed the ovary and it came out to be dysgeminoma. And after 2 years, till 2 years, she didn't get any recurrence. After 2 years, she conceived again. And at the time of next pregnancy, other ovary was quite normal. And my oncologist told, you need not even do the biopsy at all. If it is clinically normal, you leave it. You need not do biopsy at all. But one more case, the size was rapidly increasing during pregnancy. And the midst of the pregnancy, we did the ovarian self-oophorectomy on one side. And after delivery, and she got a normal delivery after that laparotomy. And within 3 or 4 months after delivery, the size again, she get the next ovary. Next ovary was also involved, and also she had a peritoneal deposits, everything. And we have done we have removed the ovary, uterus, everything, because she got only one child. It depends on the grade of the tumor also. We'll conclude with this. Thank you, ma'am, Sambat ma'am, for this opportunity. Also thank all the panelists for the excellent discussion.
Very practical.
Thank you.
Fantastic cases, Dr. Jayamala and Dr. Shanmugavadivu and our expert, Dr. Saravana Kumar, panelist, Dr. Radhika, Leena, and Swati. Swati was there or not? I couldn't tell.
She was not there.
She was not there. Okay. Anyway, fantastic.
Thank you.
Radhika from
good case selection, Shanmuga. Case selections. Your own case is very nice.
Thank you.
Thank you.
Thank you,
ma'am.
Okay.
Thank you, ma'am. Thank you, ma'am.
Radhika, would you like to tell the vote of thanks or?
Yes, ma'am.
Yes.
I'll just
for completion, we'll do the vote of thanks by Dr. Radhika. Shanmugadi and Jayamala, really good cases.
Thank you, ma'am.
Madam Revati, madam, this time Kaminira orator is from Salem.
I know. That is from Salem and Trichy. All societies are doing very well.
No, Kaminira orator is only from Salem.
We are trying our best, ma'am.
Priya.
No. This is that some sort of a this thing is coming one from each society. Credit to in Foxy.
Madam, கொஞ்சம் திட்டுங்க மேடம், அவங்க மேனேஜிங் கமிட்டி மீட்டிங்க்கு வர மாட்டேன்றாங்க. சேலம்
பிஸியா இருக்காங்க போல இருக்கு.
இல்ல எவ்வளவு பொட்டன்ஷியல் கேண்டிடேட்ஸ் இருக்காங்க, வெளியவே வர மாட்டேன்றாங்க. எனிவே அது தனியா வச்சுக்கலாம். டாக்டர் ராதிகா.
Yes, ma'am. Thank you, madam. I thank Revati ma'am, Dr. Cynthia ma'am, and Dr. Sampath ma'am, and Dr. Bhaskar sir, who our professors who all agreed to come and grace this meeting. And I also thank Dr. Supriya for her excellent talk on menstrual hygiene. I thank the judges, Dr. Nidhi and Dr. Vijayalakshmi madam, who regularly listen to the talks and give their feedback. I also thank the speakers. Both speakers were excellent and a very interesting talk on endometriosis and PCOS on adolescents. And I thank Shanti madam for judging, for presiding the session by Dr. Supriya ma'am. And I also thank the panel discussion conducted by Dr. Shanmugavadivu and Dr. Jayamala ma'am. Both of them excellent cases and excellent discussion also. And thank you, Saravanan sir, for attending this CME. And I thank Supriya and Mrs. Sripriya for the IT support. Thank you very much, Madam.
Radhika, first to thank all the delegates.
All the delegates, yes, ma'am.
Without the delegates, program is nothing.
Yes, ma'am. Thank all the delegates.
62 delegates with
Super.
the 30 faculties. So more or less around 100.
100.
Good
Thank you,
program.
ma'am.
Thank you, Radhika,
Thank you.
for your
Thank you, ma'am.
from the 4:30 to 6:30 continuously moderating the CME. Thank you,
Thank
Dr.
you, ma'am.
Radhika and all. Dr.
Thank you.
Madam, thank you.
Thank you, ma'am.